Cait is arts publieke gezondheid in Amerika. Ze is directeur van OpenNotes. En OpenNotes zet zich al tientallen jaren in voor een volledig open dossier. Ze staat echt voor het recht van mensen om volledig hun eigen dossier in te zien. Jullie zijn voorlopers om open dossiers te gebruiken en dat ook kan helpen om de zorg te veranderen. En OpenNotes hecht meer waarde aan het belang van de patiënten dan aan bezwaren van professionals. En nu ga ik toch iets meer voorlezen. Cait, welcome here to you here in the Netherlands and out our conference. I'm very proud that we can announce you as speaker about the work of OpenNotes. Thank you for your kind offer to come us and to join us here today. We hope you will inspire us with your experience and research. So I would just say the floor is yours.
Thank you.
Yes.
Thank you. And thank you to Janine for inviting me to come to speak today. I'm really pleased to be here. I'm going to talk today, I'm going to tell you a bit about OpenNotes, but the focus of my talk today is really going to be about how did the idea of sharing clinical notes with patients go from a very fringe idea. It was a crazy idea. That really started to get some traction around 2010. How did it go from being that crazy idea to being regulated and mandated in the United States over a 13-year period? I always like to have this conflict of interest slide in here to just say that OpenNotes is not a technology or an app vendor. We're not an electronic health record. We're really an idea around transparency. We have no financial conflicts of interest in that we don't take any money from for-profit corporations, including electronic health record vendors. All of our funding comes through grants from federal agencies, so our government agencies and foundations, and a few individual donors. Our story starts off in the 1970s when hospitals in the United States started to adopt a patient's Bill of Rights. And in that Bill of Rights were ideas that stressed that activities had to have an overriding concern for the values and the integrity of patients. So that began in 1973 and sort of slowly grew in the United States. In the 1980s and 90s, the movement to actually measure patient experience, so to ask patients what happened to them, were they satisfied with the care that they were receiving, would they recommend it to others, that was really a new idea in the 80s, in the early 80s, and began to spread and is now fairly commonplace. The fourth piece of kind of the stool that OpenNotes sits on is called the Health Insurance Portability and Accountability Act. In the United States, we just call that HIPAA, and it's an extremely complicated act, extremely complicated law that governs who can look at your healthcare information. But the easiest piece to understand is that it gave patients the legal right to get copies of everything in their healthcare record. Now, it was not easy for patients to do that. They would have to usually go to the basement of some healthcare organization and fill out forms and often pay for that record, but they did have a legal right to access it. But not very many people did it. The next big thing that happened was in 2009, and that was the American Recovery and Reinvestment Act, also known as ARRA. That act provided billions of dollars in incentives for healthcare organizations and physicians to adopt electronic health records. And part of that electronic health record, one of the things that it had to do was give patients the opportunity to view, download, and transmit their healthcare information. So you can see, this is a chart of the growth in electronic health record adoption in the United States. So beginning down back there in 2008, very few physicians in the United States had an electronic health record system. By 2015, we see over 80% had at least a basic record that allowed patients to log in through a patient portal. Patient portal access grew a bit more slowly, although it's growing. And if you look at the numbers post the COVID-19 pandemic, you see a big jump up in the numbers as a lot of care went virtual during that time. But you can see that by 2020, a little over a third of American adults had accessed some kind of information through a patient portal. So that's all going on in the background. And at the same time, in 2010, this crazy idea began of we should show patients what clinicians are writing about them after a visit. This was a pilot project. It began in 3 healthcare organizations, one on the west coast of the United States, so over in Seattle. It's an urban hospital that served a fairly underserved population. We had one organization that served rural patients, and then a third, my own organization, which is an academic medical center in an urban setting. We had 100 primary care physicians who were sort of voluntold that they were going to participate in this pilot. And they just opened up their notes to patients. So through the patient portal, suddenly about 20,000 patients could read the notes that clinicians wrote after a visit. After a year, the findings of this year-long pilot showed that the patients absolutely loved it. Almost all of them logged on at least once and read a note. 99% of them wanted this kind of access to continue, and that was even among patients who didn't log on and read a note. They still wanted to know that they had the option. 75% reported some kind of important benefit, like, I understand what I'm supposed to do next. I remember my care plan. I'm doing a better job taking my medications. I read my note, and now I understand why I need to get that test or referral. And despite a lot of worries, clinicians were so worried that they would be, that their offices would be overwhelmed with phone calls and emails and upset patients. The most common comment was, "Are you sure that this is turned on? Because I am not hearing from my patients the way I thought I would." The email and phone volume, which we tracked over the pilot period, that remained unchanged, was a flat line. And all providers knew that they could turn off access. They could tell their patients, "I'm sorry, we're all done. That was a pilot. We're not doing it anymore." And none of them chose to do that. So on the strength of these findings, we moved into the next stage of how did OpenNotes get going. And those are what I call the spread years. So here we were trying to move from these 3 separate organizations to create a national movement. I want to highlight something here. The average length of time between when something is published in a journal and when it becomes average, just everyday practice, how long do you think that is? It's 17 years. It takes 17 years on average. We did not want to wait 17 years. After seeing what we were seeing in our pilot findings, 17 years seemed like a really long time to wait for something that's pretty inexpensive to do, patients really love, and clinicians say, this worked out fine. It really wasn't that bad. So how did we do that? How did we go from 2010, create this crazy pilot study, to federal regulation? There were really 4 things that happened. One, generous funding for demonstration and additional research. This is quite unusual for foundations to want to fund this kind of spread work. They typically want to be in at the beginning. But we had 4 very forward-thinking funders who came together to give us some generous funding for this phase of the work. This phase of the work coincided with some national trends that helped us, and I'll talk about those. We also had new findings about what happens when notes are shared beyond primary care into other specialties. And then finally, there was work that was going on in the background with EHR vendors. So, generous foundation support. We had a road show. The woman there is Liz Salmi. She is a patient advocate and an expert in communications. She's my communications director. And we paired her with this guy, John Santa, who is a retired physician. The 2 of them would go to any meeting that anyone would have them at, where they talked about, Liz talked from a patient perspective about what it meant to her to be able to see her notes, and John talked about it from the clinician perspective. And they went everywhere, and that helped to raise awareness. Our other dissemination strategies included, of course, social media. We formed regional collaboratives, so we tried to get organizations together to foster regional competition among organizations. We had partnerships with EHR vendors. These were not financial partnerships, they were just sort of thought partnerships where we would get together and talk about what we were learning, what patients wanted, and what they could do from the technology side. We did partner with professional organizations to try to get buy-in from clinicians. The discomfort that we saw in the pilot study was not localized to our 3 organizations. This was something that we heard at every organization that we talked to. And then we also partnered with patient advocacy organizations who were interested in this idea and felt that it would be helpful for their members. So we did a lot of pairing of clinicians who were kind of clinical champions and patients who were saying, hey, I really need this information to do a better job managing my care. And that kind of a pairing appeared to be really effective in sort of getting people to say, well, okay, maybe we can give this a try. The second piece is this growing patient movement. In the United States and globally, there's a discussion going on about who owns my data, who can have access to my data, what can they do with my data, and what are my rights to that data. And that happens both in kind of the consumer world, but also in healthcare. There were many patient advocates out there at the time who were saying, this data's mine. I generated this data for you. So why am I the last one to have access to it? Third, we had new findings. We had prominent healthcare organizations such as the Veterans Health Administration, which administers healthcare for all U.S. military veterans. They adopted OpenNotes in 2015 nationwide. We had other large organizations like large academic medical centers and other premier organizations that decided to do this. And their experience turned out to be very similar to those in the pilot. So that helped. We had findings around safety. So this turned out to be a really key component for lots of healthcare organizations when we were able to say, when you let patients see their notes, they will tell you that there are clinically important mistakes in them. So we've done several studies where we've talked with patients about, well, what kinds of mistakes are you finding in your notes? And there are things like medication dosages that are 10 times higher than they should be. One particularly sort of poignant example is a woman who said, my note says that I don't have the gene the gene that makes me very susceptible to breast cancer, but in fact I do have that gene. So when we pointed out that patients could find these clinically important mistakes that clinicians also said, yes, that's a mistake I would want to know about, then the risk managers started to get involved and said, oh, well, this is a good idea. We should be doing this. And we also found that even when patients found mistakes in their notes, seeing their notes gave them increased trust in their providers. This was particularly true among patients who are from medically underserved communities, who are from minoritized communities. Being able to see that note, or even just knowing that the note is available, conveys a relational benefit where patients feel better about you as a provider and you as an organization. And we also found that these benefits held when you moved beyond primary care, so into the specialties, even among specialties where there are questions about, is this a good idea? Mental health notes, we see the same kinds of benefits. Notes around substance use disorder, we see the same kinds of benefits for patients. So those new findings help to kind of give people some feelings of safety around, well, this will be okay. It isn't just a primary care phenomenon. So this is a map. We used to keep a map going on our website that showed, it had a little counter that showed how many millions of patients had access to their notes. So after the first few years of our spread work, we had moved from our 20,000 patients at the pilot sites to over 6 million patients with access to their notes. So all of these organizations on here had a patient portal that they allowed patients to see their notes on. And how we came up with this number is we got organizations to tell us, how many people do you have signed up on your portal? And then we just added it up. So you can see in 2015, we were starting to move across the country. Those orange dots are our veterans health organizations, and they're in every state. The purple states meant that there was a private, non-government hospital that had adopted OpenNotes. And by 2018, we had moved across the whole country. We were over 33 million patients with access to their notes, with a kind of heavy concentration on the West Coast. So the spread efforts were starting to work. At the same time, vendors were making it easier for EHR vendors were making it easier for organizations to offer this to their patients by making it a default setting that organizations had to turn off, and making it just easier to navigate to notes on the portal. So as all this spread work was going on, there was a lot of policy activity that was happening at the same time. In 2016, the US government passed the 21st Century Cures Act. That was primarily an act aimed at increasing biomedical research and innovation, but there was one piece in the act that said that patients have to have access to all of the electronic data that's held about them in their record without special effort or extra cost. So this was a very small piece of the law, but had enormous implications for the kinds of information that patients could have access to. And by sort of the middle of 2018, people like Barack Obama were tweeting about, this is my information, I ought to have access to it. So we were really starting to see a national conversation. 4 years later, it took 4 years of discussion to figure out, what does all mean? What does it mean to say patients can have all of the information in their record? And we started out with just, this was the list of things that patients had to have access to and had to be easily exchanged between healthcare organizations. And you can see clinical notes is down at the bottom there. By October of last year, the policy sort of moved along in a stepwise fashion, and by October of last year, the law said that patients have to have access to essentially everything that's in their record. There are some exceptions, and if people have questions about exceptions, I'm happy to talk about that, but they're quite narrowly written, and they have to be applied on a patient-by-patient basis. So the other thing I want to just make sure to tell you is that not only do patients have to have access to their information, but they have to be able to access it with any third-party app of their choosing. So you could code an app that downloads all of the information from your record, organizes it in a way that's easy for you, maybe includes translation software that lets you see your note in plain language or in another language if you speak another language. So the third-party app piece, I think, has huge implications for how patients will access their data going forward. Despite all of that, there are still questions. I don't want to leave you thinking that we have totally figured this all out, because we for sure have not. And I think the main questions that are pressing now that we have this new law is, first, how do we do this in a way that lets patients know they have the right to access this information, that they know what notes are. Many people have no idea that clinicians even write notes after they see them, let alone why they might want to read them. So making sure that organizations implement this in a way that's very robust so that we get to a benefit. There's no benefit to transparency if no one looks at what's offered. So getting to that benefit stage. Second, and this is something I know that many of the people in the room have wrestled with, is what do we do about adolescents? It's very complicated. And in the United States, we have an added layer of complication in that many of our states have different laws around what the adolescents can access, what parents can access, what age should adolescent patients have their own record. So that's an extremely complicated question. Third is, how do we share information with others that are involved in the patient's care? And by this, I mean informal care partners. So loved ones, trusted family members. This information is also very helpful for them as they try to support the patient in their care. So including care partners in our discussion of how do we implement. How do we ensure that we're not just widening the digital divide? This was a discussion earlier today, but we do know that not everyone is given the same opportunity to access their information. Much of our OpenNotes research, I think, sort of echoes some of the work that you talked about earlier today, in that when patients who speak a language other than English or who have fewer resources, when they do read their notes, they're actually more likely than better resourced patients to say, this was very helpful for me. So how do we ensure that those patients are having the same opportunities to access information? And then finally, we have a huge debate in the United States. I don't know if you are having the same debate here around workload around the electronic health record, messaging, having to respond to patient messages, overload around alert fatigue. Anything that has to do with the electronic health record in the United States is very challenging for clinicians to even want to talk about. So how do we make sure that we are sort of honoring the work that clinicians are already doing in the EHR and make sure that this is implemented in a way that benefits patients, does not increase workload, and has benefits for both? So I would be happy to take any questions, or do you want to move on to Maria and do questions at the end?
You have time for questions.
Okay.
Ben jij mag vertalen, Janine? Of je moet hem zelf in het Engels stellen.
Zijn er vragen? You talked about sharing medical information in apps, and apps are possibly very unsafe.
Yes.
So how do you react on that part?
So our government has kind of taken the stand that it's buyer beware for patients. So patients should look at the terms and conditions of any app that they're using, which of course we all know is impossible. No one reads terms and conditions. So there is a groundswell of movement among patient organizations to create a patient digital bill of rights that app developers would adhere to, that would include things like very plain language terms and conditions that explain clearly to patients what their data will be used for if they choose to use this app. But you're absolutely right, that is a serious concern.
Andere vragen?
Voor je zin.
I have a question. You talked about the adolescents, and you mentioned briefly the parents. That brings me to the question: is what is the role of what is the responsibility of the parents when can they see of course, I think the data of their children, but where is the border? Where does it transcend from children to parents? So that's the first part of the question. And my second question I'd like to is, did you also investigate the effects on the collaboration between the medicals or the professionals around the patient?
Mm-hmm. So your first question, the answer that I have to give you is that it is very variable. So there are states in the United States, Georgia in particular comes to mind, where where parents have access to their child's record until their child is 18. They can see everything in the record. In my home state in Massachusetts, when a child turns 13, the parent then has access to a very limited set of information. So it really varies, and then there are laws around certain types of information that have to be kept confidential, like discussions about reproduction, contraception. Those kinds of notes can't even be shared to the portal. So it's a very fluid and complex situation. Some places in the United States have simply just decided that adolescents cannot have access to their information because it's too difficult. It's too difficult for them to keep the confidential information confidential. For your other question, we have not really looked at whether transparency changes the way medical professionals work together. We did ask whether, do you feel that your notes are less useful for other professionals now that you've gone to OpenNotes? And it's a pretty small percentage of clinicians. It's around 15% that say, my notes might be a little bit less useful because and the things that they say that they're more careful writing about are things like differential diagnosis, this could be nothing or it could be cancer, those are things that they're not putting in the notes as much as they might have otherwise.
Er is nog ruimte voor een vraag. En nog andere achter in de zaal is ook nog een vraag. In het midden.
The lights are very bright.
Ja.
You can see in the back.
Hi. I'm a technology vendor, so I'm interested in a technology question here. So the legal requirements for the patients to have the possibility to share it with any app they would like to use, of course, requires some form of technology that allows to share it.
Yes.
Did you see any convergence to standards on this type of sharing, and if so, has this been taken a big launch during the COVID pandemic, and or because of course legal requirements and what technology can do at that moment might be way apart. are they converging right now or not?
So in the United States, our Office of the National Coordinator for Health Information Technology, which is a federal government office, it creates certification standards for electronic health record vendors. So if an electronic health record vendor wants to be certified, and they generally do, it's financially good for them to be certified, they have to offer an open API, and that open API needs to use FHIR standards. So that's where we are, and more EHR vendors are adopting that. And you can see, if you have an Apple phone in the United States, there is in the health app, there is an option for you to link to your patient portal and pull all of that information right into the app. So it's definitely happening, it's in the early stages, and they are using those FHIR standards. And I don't know that there's been a big jump up in app usage after the pandemic. It's pretty early days still in terms of the open APIs being available. I think we're maybe a couple of years off before we really start to see that.
Dankjewel voor je vraag. Dat was een van de bouwers van het jeugddossier. Dus vandaar de technische vraag. We zijn door de tijd heen voor de vragen. Cait, we are of the time. Thank you for inspiring your presentation and how encouraging to hear that our experiences are similar. Good luck with your work at OpenNotes and the future development of patients' accessible health records. Thank you.
Thank you.